Can't tell you how excited I am as a nurse to hear about Betty Newman. I mean, yes, those things work. So while people can come up to the mic to ask questions, I wanted to ask the panelists a question that has come up a few times during the day, and that is about workforce. So this is, in some respects, exciting work, in some respects, challenging work, limited work in terms of availability. What are your thoughts? Is that an issue for you? How do you handle that? What are you looking for when you recruit for staff?
So workforce is always a challenge, especially in the state of Kansas where we have a horrible nursing shortage. We don't have enough nurses. We don't have enough primary care providers by far. So it's something that we're trying to address by partnering with not only medical schools, but nursing schools, and we provide a platform for them to get education and learn, following us, following our programs in our PACE program, hospice and palliative care programs, and our home health programs. So we constantly have med students, residents, nurses, nurse practitioner students with us all the time. So that's one way.
So you're kind of growing your own?
Yeah, we're trying to grow our own, but for me, it's actually more important about, and I've heard several of the panelists say this, it's providing that level of education at the beginning of their educational experience so that they get exposed to that much. In my medical school, I had one hour lecture on hospice in 4 years. I mean, that's not appropriate. And so we have to change that. And so I'm doing some things in my local community to try to do that. And then the other thing is really reaching out into the communities we serve and trying to partner with those sort of health systems or community resources to help with that, because this isn't going to get better. It's going to get worse. That's what we're doing.
Yeah, so this is literally my favorite topic in the whole world.
He did not tell me that before.
Yeah, lots of thoughts. I'm just trying to organize them. I'll start by saying that there are a lot of very mission-driven people who have nowhere to go. They literally have nowhere to go. You have phenomenal trainees, graduating residencies, and fellowships who want to change healthcare, and then they get treated like a replaceable part. And one of the concerns that I have in a dialogue like this one is that there's so much emphasis on the model. It's not about the model, folks. It's about the people. The model is really only as good as the people who operate within the model. And I will tell you, as a leader of an organization like CareMore, I spend more of my time on people that people think I run human resources and not the company. Recruitment of passionate, mission-driven, highly capable, clinically competent, intrinsically motivated, excited clinicians is it's the secret sauce. The product is the clinical care, and so the ingredients are the people. And so you're not going to unlearn. If you have a bad apple resident or physician, no amount of onboarding or training or academies is ever going to get them to treat the patients the way you want them to be treated. And as you think about scaling organizations like CareMore or any of the organizations that have been represented today, the rate limiting step, and where I see a lot of organizations going wrong, is when they start hiring warm bodies. And when you start plugging warm bodies in, and when you start treating people like they're warm bodies. And so you say, oh, I need somebody who's going to do my weekend shifts. And your number one recruitment criteria is shift coverage. It's all over. The game is over before you began. And so, if I can just pass one lesson on, from my work, it's to just focus on the people and the culture and making sure you have the right people seeing your patients, because you're not, when you start to scale, you're never going to be able to be in every single room, and you need to have people who you trust to make the right decisions by your patients, every single day.
So I think that's a multifaceted answer. I think recruitment and retention always comes to mind for everybody, right? So in a program like Tandem, where it's so different and it's a startup, to recruit the right staff from the get-go is so important. And we did have a lot of turnover in the beginning, especially from nursing. Not social work, but nursing had a difficult time wanting to always focus on the task and the medical intervention versus the whole person. So that was really tough. So how we've addressed that part, at least, is a really robust orientation selection process of getting the right people at the get-go. And then from there, that experience of how long does it take to get them embedded in your philosophy and the culture of what you're trying to do. And we finally figured that out. It probably takes really at least 12 weeks of really embedding them with a preceptor, and we created preceptor programs to help to do that, so at least retention is stable. And the next part of that, and I kind of touched on it a minute ago, resource management is huge, and letting everyone practice within their scope. I think that's key. So when you have paramedicine practices, community paramedics, sometimes that's a hurdle in itself. What exactly can they do? What scope of practice? What will their medical directors allow them to do? So that's been a journey as well for us because it was new in Michigan. And the one that we work with, that program happens to be the most robust and one of the first to do it. So we've been able to carve out a lot of things, including teaching them to do catheter changes and port access and things like that, where normally nurses would have to have done that. We've changed that philosophy because it's all hands on deck at Tandem. It has to be. In order for everyone to have a touch and as many touches as we want and to have the right touch, everyone has to be involved, including the MAs. What can MAs do within their scope of practice? This took me a lot of time with attorneys to go, do I have the legal right to do this with an MA? And so then what is the RN's responsibility, right? Always at the top of the ship, it seems like, has to be the one overseeing all these things. And then how happy does that make them? But the reality is, that it's not always about doing it every person that we have there. Not everyone has to touch in the same way, but we all have to have touches. That's kind of how we've handled it. So I have no idea about the future, but.
Well, I think this is a problem we all deal with. So we have some questions. Tim, do you want to start off?
Hi, I'm Tom Quinn. I'm currently working for a small community hospice in Montgomery County, Maryland, locally here. And I've done home care in two other areas as well. And those of us who have done home care certainly understand this whole social determinants issue. I'm kind of blown away, though, Teresa, that you were able to actually get an insurance company to trust that you could do something to help keep these people out of the ER and all of that sort of thing, when almost everybody else thinks of those as medical issues. So how did you get to first base?
That's part of the story that I could spend all day talking about, but I think a lot of it had to do with the providers that are now owners of Tandem had really great facilities. I don't really like to call them that, but their skilled nursing and rehab units are phenomenal. They deliver really great care. And their reputation in the community of over 100 years means something, so I think that's one advantage. Plus, Priority Health is a local player in terms of being in Grand Rapids, so you can be in front of those people, and you have to be in front of them constantly. You have to bring your stories, you have to keep talking about what's important. I mean, obviously, they're going to be talking about the numbers, right? I mean, just from an analytics perspective and getting an outcome measure is the most difficult thing I've ever seen. They give you a number and then they back out and say, I don't know, we don't know if that's right. So we're still playing that game. But to even get to the level where we can have the conversation, and we just said, give us a pilot. Just let us show you. 150, that's all we're asking for, and that's really how it started. And that's how it's starting with Blue Care Network. Give us 100, let us show you, and then you tell us how we're doing.
Katrina Scott from the Association of Professional Chaplains. You're all talking about a holistic model as well as involvement in community care. And I was wondering if you have in place outreach for faith communities, because for a lot of folks, that's where a lot of support is found. So I was just curious if you include that in your models.
It's definitely included in the PACE model because the chaplain's part of the team, and the chaplains are connected to all the local faith communities. But as a side note of that too, I mean, we are out often talking in those communities about the resources we have available to help them should they need services and that. But chaplains spiritual care is an integral part of PACE. Certainly should be a palliative care and hospice, but definitely of the PACE model. They're always at the table.
Our care centers are very neighborhood based, and so there's a strong connection between the care centers and then the communities around them. And lots of people say all healthcare is local, and we explicitly take this very micro system view of patients and their neighborhoods, and try to embed them in their social context. So yes.
So I think that's an interesting question that you propose. I didn't tell this earlier, but our 4 retirement community partners are all faith-based and not of the same faith, I might add. So that makes it even more interesting, but they're at least Methodist, Christian Reform, and Presbyterian. So that helps. But then a lot of the 2 hospices we work most with are also faith-based and have chaplains. But when we look for volunteers, we always go to their churches first, the person's church. Now, we know that a lot of people aren't they don't have a relationship with the church, and then that's when we have to go outside and look for other support. But it's a good question. It made me think when I read through some of the literature that for this presentation about the chaplain use and how we could maybe capitalize on that a little more than we do.
Yeah, we're really well-kept secrets.
Yes.
Yes, this is for David. Maybe any others want to react. First of all, I really appreciated your presentation on PACE. Early in my career, I had the privilege to work with Unlock and really create the vision for the PACE demonstration program, and actually saw it through. And I hadn't seen those evaluation results in a long time.
Thank you.
But they really were great. And the other thing you didn't point out up there is the health-related quality of life outcomes, and that were just off the charts, which really showed the patient-centered nature, I think, of that program in a major way. One thing you mentioned was, you said you're among the most regulated, aspects of healthcare. I think nursing homes might want to give you a run on that point, but the point is that these are real investments for states, to really invest in your program, as well as for investors and others in the delivery system. And you mentioned about being able to reach out to rural areas and bring your services out. Why can't we put this on steroids? Why can't we think about kind of a population-based strategy to really thinking about PACE in the same way that we think about accountable care organizations, as a way to try to, make that outreach? We've heard a lot today about telehealth, about interesting partnerships and co-location of services. Why can't we just make the leap?
Wow, that's a big question. So a couple of things that come to mind when you say that is, so we do all of those things. I mean, I don't have time to explain all the things that we do in PACE because it's so complex. So we do telehealth, we do telemonitoring, there's so many things that we could scale. The limiting factors right now is really the upfront investment to launch a PACE program, because it is a multi-million-dollar endeavor, because it is currently under the current guidelines and restricted to being a PACE-centered based kind of process. Even though we provide PACE services in many rural areas where there are no centers, you still have to have that as part of the core of being a PACE program. So that limits, sometimes I think, that scalability. The other thing is the population that we're serving is so frail, and what I'm finding in our population is many of them don't have caregivers anymore. That idea is gone now from most of the people we serve, because a lot of the population we're serving in the Medicaid onlys or the dual eligibles, they're teetering on homelessness all the time, and they're hungry. They don't even have food, and so we're just trying to figure out how we manage that. They're often in the hospital because they can get a meal. I mean, we're just trying to help manage that so that we can get them the resources. So how do you scale that up to a larger population? I think is possible, but it has to do with those restrictions of the being a PACE center and having all those requirements there available for PACE to grow. So, but it has grown a ton. So thanks to the work of Unlock in the beginning, when I started, we were the 32nd PACE program in the country. Now there's 141. So, I mean, it has grown. It's just really slow because it's so cost prohibitive to do it. And then the other thing we did in our state, we had that cap of 50 patients that we worked really hard with our state legislators to get lifted. And at the same time, our state Medicaid system went to managed care. And so we also got them to present PACE as a fourth option to the Medicare sort of, or Medicaid sort of stuff, which was another big win for our state in terms of the population that we're serving the most. Because now if a person's applying for Medicaid and they meet the criteria of 55 or older, and they have been certified by the area agencies to be at nursing home, they offer PACE as one of the options to them. And we work really hard to keep them out of the nursing home. So those are the things I see holding PACE back.
Let's take one last question, Joanne.
Boy, would I love to follow up on that conversation. There are 30,000 people in PACE, and there are 30,000 people who need it between here and Baltimore. The size dimensions, and it's not just the startup costs. I mean, we've constrained PACE in 1,000 ways because it was scary in 1990. It is not scary now compared to what else we're doing. But I really wanted to pick up on what you were saying about the social needs. We've talked today, everybody who's talked about connecting people with social issues talks about it as if it's navigation, referring people to places. I mean, they aren't out there. There isn't the housing, there isn't the food. It seems that one of the things we really need to work on is how to make sure people have housing, food, basic transportation, cleanliness. How do the other two of you deal with the shortages? I mean, PACE just has to make it up for a very small number of people. But you've got to be working in areas in which you simply cannot get what somebody needs to have. Should we have a march on next Saturday for this, or have you thought about going to public action and trying to get better allocations, or do you just sort of live within the constraints of what the community provides?
Pass.
I'm happy to take it.
You don't have to answer. I mean, we could take it up more broadly. The next workshop is on financing
Thank you.
of advanced illness.
Seems like a good answer.
So, I will say the marriage of payer and provider is a theme that's come up, all day today. And, there's some questions about how do you get an insurance plan to play well with you. I think the answer really is in the closer relationships between payer and provider organizations. I didn't have a chance to get, kind of get into all the details of the evolution of CareMore, but it initially was a fully delegated group, and one day they said, forget it, we're going to start our own health plan. And that, I think was very empowering as well as very scary. And I think that unity creates a common bottom line where you're thinking, where common sense prevails. I mean, that's what we're really talking about here, is actually unleashing the power of common sense to do the things you need to do to keep your patients out of the hospital and keep them well. And so that's how we ended up providing transportation benefits. That's how we ended up giving dehydrated patients air conditioners. It was letting that kind of common sense prevail. And I think that is uniquely enabled by payment models where either the full dollar is moving to the provider or there is that marriage between the payer and provider. And CareMore is now a part of Anthem, and I will say one of the most exciting things really has been our Medicaid partnerships, where we do have this very tight relationship with our plan partners, and we're not a vendor. And I will tell you, when I know that things are going badly in that relationship is when they start talking about us like we're a vendor. And I think it's about speaking like partners, where you actually have a common goal, a common set of activities that you're trying to accomplish. And I will say, being a provider organization within a large health plan organization, I think there's a language barrier. I think there's a way in which we think about patients that hasn't necessarily been communicated across the cultures of health plans and delivery systems. And, the demonization that's happened over decades of, brutal battles over price, right, have gotten in the way of kind of more constructive dialogue around, it's not quality, it's actually just common sense. And so I think there needs to be a reframe and a commitment to relationship building that, doesn't imply a moral judgment, across sectors. I think I'm the only person in the room who's worked for pharmaceutical companies, worked in academia, worked in, for the Veterans Hospital. I can't keep a job is what I'm really trying to tell you. A health plan and a healthcare delivery organization. I will tell you the conversations that happen across sectors are so uninformed. Everyone talks about everyone else like they're somehow out to get somebody else, and sometimes that's true, but oftentimes it's based in really poor knowledge about what's actually happening across sectors, and I think that's a really important gap that we can all help to solve.
All right, and with that appeal to common sense, thank you to this wonderful panel, and we're going to go straight to the next panel.